The biological function of PCT is probably no longer clinically relevant. It seems to be a vestigial molecule, but it has a minimal effect on calcium homeostasis. It may modulate endotoxic shock. High levels suppress TNF-alpha, and high levels have a pro-inflammatory effect. In health, procalcitonin is produced by the C cells of the thyroid gland. In septic states, multiple organs produce procalcitonin, primarily from circulating monocytes, hepatic cells, and hepatic monocytes. The production of procalcitonin is limited in health, but it comes from multiple organs in sepsis, as you can see from this gastromatograph on the right. So procalcitonin is cleaved intracellularly, hence serum levels are very low, but during severe infection and sepsis, procalcitonin plasma levels may increase to over 200 nanograms per mil, normal levels being less than 0.05 nanograms per milliliter. This increase in procalcitonin is not accompanied by an increase in plasma calcitonin levels. Procalcitonin has a half-life of 25 to 30 hours in the bloodstream. You look at this graphic showing the release of these various inflammatory mediators following an endotoxin challenge in human volunteers. See IL-6 and IL-10 go up fairly rapidly, as does TNF-alpha. PCT takes about 2 hours to start increasing in levels, but then starts to drop down fairly rapidly once the endotoxin is removed. CRP lags in its elevation and lags in its decline despite clearance of the endotoxin. In about a 24-hour period, the PCT levels usually come down by about 50% in the setting of normal renal function. This is a composite of several studies looking at the sensitivity and specificity of procalcitonin in red and CRP in the yellow. PCT pooled sensitivity in this group of studies was about 88%, and the pooled specificity was 75%, looking at the summary receiver operating curves. This came from a study published in Critical Care Medicine in 2000, looking at the calcitonin precursors compared to CRP, IL-6, and lactate as markers for sepsis. The calcitonin precursors sensitivity on this study was about 89% with a specificity of 94%. The negative predictive value was 90% for procalcitonin, and the positive predictive value was 94%. Clearly superior to CRP and lactate. IL-6 is not really commercially available for everyday use. This next study, again published in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine, 2001, looked at the utility of procalcitonin, and in addition to the clinical model of defining sepsis using the same definitions as we looked at earlier. The graph on the left-hand side looks at the receiver operating characteristic curves of plasma PCT, interleukin 6, interleukin 8. You can see with that, using a cutoff level of 1 nanogram per mil for procalcitonin, the sensitivity was 97%, the specificity was 78%, somewhat better than interleukin 6 and interleukin 8. On the right-hand side, you look at the graphic showing the sensitivity and specificity of a clinical model with PCT in the upper curve compared to the clinical model without PCT in the lower curve. So if you just look at the clinical model, your sensitivity and specificity is significantly less, of 0.77, but if you add to that procalcitonin, sensitivity and specificity was significantly improved in helping diagnose septic patients. If you look at the levels of procalcitonin from the same study, there's a range, but you can see it's an increasing range on a logarithmic scale, comparing SIRS to sepsis, severe sepsis, and septic shock, where the numbers can be extraordinarily high in seriously ill patients. The kinetics of PCT are interesting as well and can be very helpful, I think. This shows the effectiveness of treatment. If you follow the red line, oftentimes you'll see a little increase in the first 24 hours, and then as you get an appropriate response to antibiotics, the procalcitonin level comes down nicely. And then in the black line, you see a lack of response or lack of reduction in procalcitonin until there's a therapeutic change, and then the level comes down. The yellow line would suggest a therapeutic failure and worsening procalcitonin and worsening prognosis. This next graphic is interesting in that it shows patient survival. If you look at over time, if you look at the yellow curve, that applies to patients who had a low or decreasing procalcitonin over time, which had a much better patient survival than if your procalcitonin was high and increased. over the few days of monitoring. So if the procalcitonin is responding, or if the patient is responding to treatment, you should see a commensurate reduction in procalcitonin, which would imply an improvement in survival compared to an increasing procalcitonin during therapy. And that was very significant, p-value of 0.0001. Looking at this another way, the same study, a high maximum procalcitonin and a procalcitonin increase for 1 day are early independent predictors for all-cause mortality in a 90-day follow-up period. As you can see, a significant mortality rate as the procalcitonin goes up by day 2 of 72% versus if the procalcitonin was sudden to come down. Again, very significant difference. So what's available right now? The earlier generation of procalcitonin testing available in Europe was using the Brahms PCT ELISA test. We now have a more sensitive test, the Cryptor test, as well as the Vitus Brahms PCT second generation assay, which provides ELISA technology with a 20-minute turnaround test. We use a stat test for some of our ER testing, as well as batch testing for morning testing that we do on a routine follow-up basis. And it has a lower level of sensitivity at 0.05 nanograms per mil for patients who at the 95th percentile. At the normal PCT level, the 99th percentile will be at 0.09 nanograms per mil. In a therapeutic setting, if the procalcitonin level is less than 0.05, you'd assume that to be a normal level. And if it's less than 0.5, then you'd expect possibly a local infection. Once you start getting between 0.5 and 2, you're probably going to be seeing a systemic infection, inflammation developing, and above 2, manifestations of severe sepsis, and then above 10, patients probably having symptoms or signs consistent with septic shock. The next slide looks at the biological variability of what happens in different tissue or different organs are affected and infected. And looking at this table from Meissner's article from 2002, you can see that looking at the difference between bacterial and viral meningitis using a cutoff of 1.8 nanograms per mil, they had 100% sensitivity and specificity. Different studies looking at different cutoff levels showed different sensitivities and specificities. For bacterial versus viral pneumonia using a cutoff level of 2, for that particular study, it was a sensitivity of 63% and specificity of 96%, and so on, looking at pancreatitis, septic shock, and invasive versus local bacterial infections. So even though we see a significant elevation of procalcitonin with bacterial infection above normal, different tissues that are infected can have different levels of activity and elevation of procalcitonin. And it's still to be discovered at what level different infection in general will give you what degree of an elevation you would see. So procalcitonin, I would think, is a novel marker for clinically relevant bacterial infection and sepsis. Elevated levels are highly suggestive of bacterial infections with systemic consequences. In septic conditions, increased procalcitonin levels can be observed within 3 to 6 hours after an infectious challenge. Procalcitonin levels are usually low in viral infections, chronic inflammatory disorders, or autoimmune processes. Procalcitonin development reflects the progression of disease from sepsis to severe sepsis and ultimately septic shock. And procalcitonin potentially has a substantial impact on therapeutic decisions and healthcare costs. Because of the rapid decrease resulting from a half-life of about 20 to 24 hours, reduction in levels would reflect effective treatment, as you'd expect it to come down by about 50% every 24 hours. There are some limitations of procalcitonin, like in any other test. There are some false negatives seen with early infection, sometimes with localized infection, and subacute bacterial endocarditis. There are also some limitations with false positives, often seen in the newborn, in severe inflammatory states such as ARDS. I've seen this develop with chemical pneumonitis, falciparum malaria, systemic fungal infections. I'm not sure I'd call that a false positive, but it's a manifestation of a fungal infection. Trauma, infusions with anti-thymocyte globulin, burns, pancreatitis. Medullary thyroid cancer as well as metastatic small cell cancer can also elevate procalcitonin levels, as well as TNF-alpha infusions, and sometimes require neoplastic hormone secretion. But with those conditions, you generally don't see the spike that you see with infection, and you don't see the response you see with treatment, and tends to be more of a level elevation of the marker rather than a elevation and reduction with treatment that you see in septic or infectious state here. One of the clinical studies that's come out more recently, which I found interesting and thought would be good to share, was the study in the American Review of Respiratory and Critical Care Medicine, and using procalcitonin to shorten antibiotic treatment duration septic patients. The same algorithm has been used in other studies, as you may know, in pneumonia and lower respiratory tract infections, bronchitis. The same kind of process was used for these patients to see if an algorithm based on serial measurements of procalcitonin allows for reduction in duration of antibiotic therapy compared with empirical rules, and to see if it resulted or not in more adverse outcomes or so. So in this study, there was an intervention group where antibiotics were stopped when PCT levels had decreased in 90% or more from the initial value if the clinicians agreed, but not before day 3 if the baseline PCT levels were less than 1 nanogram per milliliter, or day 5 if PCT levels were less than 1 nanogram per milliliter, that should read. In the control group, the clinicians decided on duration of antibiotics based on empirical rules. Patients were assigned to the PCT group had a 3.5-day shorter median duration of antibiotic therapy with a p-value of 0.15. Procalcitonin guidance resulted in a 4-day reduction in duration of antibiotic therapy per protocol, p-value of 0.003, and a smaller overall antibiotic exposure with a p-value of 0.0002. There was a similar mortality and recurrence rate of the primary infection observed in the PCT and the control groups, and overall a 2-day shorter intensive care unit stay was observed in those patients whose therapy was guided by a reducing procalcitonin. Again, significant.